In this series of oncology, we are going to learn about head and neck cancers. Let's look at their etiology, genetics, histopathology, clinical presentation, TNM staging and treatment. You can find other lectures of oncology in the playlist linked in description.
Let us observe the anatomy of the human head and neck. We are mapping where these diseases originate. The vast majority of these malignancies are known as epithelial carcinomas. This means they arise directly from mucosal surfaces. Mucosal surfaces are the moist linings of the respiratory and digestive tracts. They are fundamentally different from other rare cancers in this region, such as thyroid cancers.
We must first examine the primary environmental causes. Alcohol and tobacco are the most significant risk factors. It is vital to understand how they work together. They act synergistically. This means their combined use does not just add the risks together. Instead, combining tobacco and alcohol actively multiplies the overall cancer risk for the patient.
There are other identified cancer-causing agents beyond smoked tobacco and alcohol. Smokeless tobacco is specifically identified as an agent that directly causes oral cancers. Marijuana use is also identified as a potential carcinogen. Additionally, we must consider occupational hazards. Certain industrial exposures function as potential carcinogens. These specific hazards include nickel refining, woodworking, and exposure to textile fibers.
Diet also plays a crucial role in our understanding of risk. A low consumption of fresh fruits and vegetables is directly associated with a higher incidence of these cancers. A balanced diet containing natural plant pigments called carotenoids may offer a protective effect. However, there is a crucial warning. Retinoid supplements, such as cis-retinoic acid, show absolutely no preventative benefits. In fact, they may actively increase cancer risk in active smokers.
This brings us to a fundamental concept called field cancerization. When a person uses tobacco or alcohol, the mucosal surfaces of the entire pharynx are continuously exposed to these carcinogens. The carcinogens bathe the tissue. This continuous exposure places the complete mucosal region at a high level of risk. The damage is not localized to just one tiny spot.
Because of this wide field of damage, patients often develop pre-malignant lesions. This pervasive risk leads to two specific clinical outcomes. The first is synchronous cancers. This means multiple independent primary tumors develop at the exact same time. The second outcome is metachronous cancers. This means second primary cancers develop sequentially over time. These new tumors can appear later in the head, neck, lung, or esophagus.
Beyond environmental factors, we also have viral pathways. The Epstein-Barr virus, or EBV, is a specific viral cause. It is frequently associated with nasopharyngeal cancer. This cancer is located in the upper throat behind the nose. This specific disease has a distinct global footprint. It is highly endemic. This means it is found at a consistently high incidence in specific regions, primarily the Far East and the Mediterranean.
Another critical viral pathway involves the human papillomavirus, or HPV. HPV is linked to a rapidly rising number of tumors in the oropharynx, the middle part of the throat. The disease is highly specific to certain anatomical sites. It predominantly arises in the tonsils and the base of the tongue. The main cancer-causing subtype driving this is HPV-16. However, HPV-18 and others are sometimes present.
We must carefully contrast the carcinogen-induced tumors with the viral tumors. Tobacco-related cases typically occur in older patients, usually over the age of 60. HPV-related cancers present a very different patient profile. They occur in much younger demographics, typically patients in their 40s or 50s. They are directly associated with oral sexual practices. Importantly, the HPV-positive tumors generally carry a much better clinical prognosis than tobacco-induced tumors. Let us examine the internal genetics of the older carcinogen-induced pathway. These are the HPV-negative tumors. They frequently contain mutations in the p53 gene, which normally acts to suppress tumors. They also show altered Notch signaling. This is a pathway cells use to communicate. Furthermore, the epidermal growth factor receptor, or EGFR, is frequently overproduced. This overproduction correlates with a poor prognosis.
We will now look at the molecular biology of the viral pathway. How exactly does HPV cause cancer? The mechanism is very different from chemical mutations. HPV creates its own viral oncogenes. These cancer-causing genes initiate the disease by actively inhibiting healthy genes. Specifically, they bind to and disable the p53 and retinoblastoma genes. These healthy genes usually protect the body from forming tumors. Once those vital tumor protectors are disabled, the cell becomes highly unstable. This leads to a cascade of further mutations in these HPV-positive tumors. Because the cell can no longer repair itself, frequent errors occur in the PI3K signaling pathway. This pathway normally manages cell growth. We also occasionally see mutations in the KRAS gene, which is another critical cellular switch. Despite having very different origins, both tumor types share core similarities. Both exhibit severely compromised genetic stability. Both show unchecked cellular division and altered cellular development. They also share disrupted mitogenic signaling. This means the signals telling cells to divide are broken. Interestingly, specific mutations in a gene called HRAS have emerged in both types. This represents a distinct, potentially targetable weakness for a small group of patients. Another crucial point is how these tumors look under a microscope. We call this histopathology. The vast majority are squamous cell carcinomas. Clinicians categorize them by grading their differentiation. This means looking at how much they still resemble normal, healthy cells. They are graded as well-differentiated, moderately well-differentiated, or poorly differentiated. Tumors that are poorly differentiated look chaotic. They are inherently associated with a decidedly worse clinical prognosis. There is a specific exception to this general presentation. Tumors in the nasopharynx often present differently. They frequently appear as non-keratinizing tumors. This means they do not produce the hard protein called keratin. Clinically, these are called lymphoepitheliomas. A defining feature is that they are densely packed with infiltrating lymphocytes, a type of white blood cell. As noted earlier, these specific tumors are strongly linked to the Epstein-Barr virus. We must also address malignancies of the salivary glands. These are quite rare and behave very differently. They are highly heterogeneous. This means they have many different, distinct forms. Unlike mucosal cancers, there are no identified environmental carcinogens linked to salivary gland tumors. Key malignant types include mucoepidermoid carcinoma and various forms of adenocarcinomas. Within salivary gland tumors, adenoid cystic carcinoma requires special attention. It exhibits a very unique and concerning tendency. It tends to recur by traveling along the pathways of nerve tracts. This makes it difficult to fully remove. We must also consider the origin of these tumors. Most tumors found in the large parotid glands are benign. However, if a tumor is found in the submandibular, sublingual, or minor salivary glands, the percentage of malignancy is significantly higher. It is crucial to understand how we visually diagnose the disease early. Clinicians look for specific diagnostic markers. They look for leukoplakia, which are white mucosal patches. They also look for erythroplakia, which are red mucosal patches. Examining these patches under a microscope is essential. We can trace their progression. They start as abnormal cell multiplication, called hyperplasia. This progresses to abnormal development, called dysplasia. This can become severe, called carcinoma in situ. Finally, the cells breach the base membrane. They become a fully invasive carcinoma. Clinicians must always perform a careful differential diagnosis. We must contrast the dominant squamous cell carcinomas with other very rare tumor types.
A clinician must also consider lymphomas, which are cancers of the lymphatic system. Furthermore, they must be aware of sarcomas, which are cancers of connective tissue. Sarcomas are an extremely rare secondary malignancy. They can occasionally be induced by prior radiation therapy used to treat an earlier head and neck cancer.
The way this disease first appears depends heavily on where it starts. The early symptoms can be persistent, but they are often very nonspecific. This makes early recognition absolutely crucial. Let's walk through this anatomical map together. Starting at the top, in the nasopharynx, cancers here typically hide. They rarely cause early symptoms. Later on, they might cause unilateral serous otitis media. That just means fluid building up in one ear, because the eustachian tube is blocked. You might also see epistaxis, which are nosebleeds, or just general nasal obstruction. Now moving down to the oral cavity. Here, patients often find painful lesions or masses. Sometimes the first sign is simply that their dentures stop fitting right. Next we have the oropharynx and hypopharynx. Early symptoms are rare in these areas too, but a persistent sore throat or atalgia, which is ear pain, can occur. You might also notice a change in speech if the tongue's mobility decreases. Finally, let's look at the larynx. This is a critical area. Hoarseness is a vital early symptom here. Any persistent hoarseness requires an immediate, specialized examination. Now, there is one major exception to these early signs. We call it the HPV anomaly. HPV-related tumors behave very differently. They frequently present with neck lymphadenopathy. That means enlarged lymph nodes in the neck. And this is often the very first warning sign, while the primary tumor itself remains hidden. As any of these head and neck cancers advance, severe red flags will appear. These include severe pain and airway obstruction. Trismus can also occur, which is lockjaw. Patients may experience odinophagia, meaning painful swallowing. Dysphagia, or general difficulty swallowing, is common too. In advanced stages, massive cervical lymphadenopathy can develop. These present as very large neck lumps on one or both sides. Knowing exactly when to suspect malignancy is vital. Many of these lesions look exactly like simple infections at first. Often they're treated with antibiotics. However, we follow a strict clinical rule. If a lesion does not resolve in 2 to 4 weeks, it requires a mandatory workup. Waiting any longer risks losing our window for early diagnosis. We also need to watch closely for premalignant lesions. Leukoplakia appears as white patches. Erythroplakia appears as red patches. Both of these must be biopsied. They could just be simple overgrowth, but they could also be invasive cancer. A biopsy is the only definitive way to know. Once a suspicion is raised, we can't stop there. We must investigate further to define the exact nature and extent of the disease. Sometimes, a patient will present with enlarged lymph nodes in the neck, but we simply cannot find a primary tumor. We call this a carcinoma of unknown primary. The specific location of these nodes actually tells us a story. If the enlarged nodes are high up in the upper neck and show squamous cells, the cancer likely started somewhere in the head or neck mucosa. Very often, these turn out to be those hidden HPV-related tumors we mentioned earlier, located in the tonsils or the base of the tongue. But if the nodes are lower down, in the supraclavicular region near the collarbone, the story changes completely. That location suggests the primary tumor is distant. It might be down in the chest, like lung cancer, or even in the abdomen. To uncover the truth, we follow a very strict sequence of steps. Step 1 is a thorough physical examination. We carefully inspect all visible surfaces and palpate the neck and mouth. Step 2 happens if the primary tumor still remains hidden. This is panendoscopy. It allows us to conduct directed biopsies of occult or hidden sites. We meticulously check the nasopharynx, the tonsils, the tongue base, and the pyriform sinus. Step 3 involves advanced imaging. We rely on CT, MRI, or PET scans. These scans define the exact extent of the disease. They also help us locate any distant spread or even second primary tumors in the lungs or esophagus. Once we have our findings, we categorize them using the tumor node metastasis staging system, commonly known as TNM. Let's break this down. The T category relies on the size of the primary tumor and its depth of invasion. A tumor under 2 centimeters with shallow invasion is considered early stage. As the size and depth increase, the T stage advances. A T4 tumor, for example, invades deep structures like bone or nerves. Next is the N category. This measures the lymph nodes. It accounts for the exact number of involved nodes and their size. An N1 node is a single node on the same side as the tumor and under 3 centimeters. Larger nodes, multiple nodes, or nodes on both sides of the neck will push the stage higher. Together, the T, N, and M values combine to define the patient's overall clinical stage. Our management framework is built on 3 distinct clinical groups. Pillar 1 is localized disease. This covers stages 1 and 2, where our intent is completely curative. Pillar 2 addresses locally or regionally advanced disease. These are stages 3 and 4, but without distant spread. Our intent here is also curative, but it demands a much more aggressive approach. Pillar 3 is recurrent or metastatic disease. This means the cancer has spread far away or it has returned after initial treatment. Here, the intent shifts entirely to palliative care. The goal is no longer to cure, but to control the disease and ease the patient's symptoms. Let's take a closer look at treating localized disease. We generally have 2 main curative options: surgery and radiation. The choice depends entirely on the patient's anatomy. Surgery is often preferred for small lesions in the oral cavity. This is because it helps avoid the severe long-term side effects of radiation, like extreme dry mouth, called xerostomia, or even bone death in the jaw. Conversely, radiation is highly preferred for laryngeal cancer. The reason for this is simple, yet profound. Radiation preserves the patient's voice. Surgery on the larynx would often mean losing that vital function entirely. When we face advanced disease in stages 3 and 4, we use an aggressive combined modality pathway. We often start with induction chemotherapy to shrink the tumor. Then we move to concomitant chemoradiotherapy. This means we administer chemotherapy drugs like 5-fluorouracil at the exact same time as radiation therapy. This combined strategy yields about an 8% improvement in 5-year survival compared to radiation alone. It really enhances tumor cell killing, but there is a very strict clinical trade-off. This approach causes extremely high toxicity. Patients must endure severe mucosal damage in the throat and mouth. While our standard treatments are incredibly powerful, not all tumors follow the standard rules. Different origins require entirely different strategies. As we noted earlier, HPV-related cancers actually have a significantly better prognosis. Because of this favorable outlook, there is a massive clinical push for de-escalation protocols. The goal here is to use lower radiation doses and omit heavy chemotherapy. This safely reduces lifelong side effects, like neck fibrosis and severe swallowing issues. Salivary gland tumors represent another special case. Their treatment diverges entirely from standard mucosal cancers. Localized benign salivary tumors usually just need surgical excision. Invasive ones require surgery followed by radiation. They simply do not respond to the standard pathways we use for squamous cell carcinomas. If the disease sadly becomes metastatic, systemic therapies become our primary tool. Immunotherapy has been truly revolutionary in this space. Drugs called PD-1 inhibitors, like pembrolizumab, actually help the patient's own immune system recognize and attack the cancer. They are especially effective if the tumor expresses high levels of the PD-L1 protein. That's a marker that helps cancer hide from immune cells. Before this breakthrough, the extreme regimen was the historical standard. That relied on heavy chemotherapy drugs like cisplatin and 5-fluorouracil. We also have targeted therapies. Drugs like cetuximab inhibit specific cellular growth pathways, such as EGFR or HRAS, which these cancers rely on to multiply. Ultimately, these systemic therapies focus on controlling the disease and extending the patient's life. Aggressive treatments do save lives, but they take a heavy toll on the body. Because of this, comprehensive supportive care is mandatory, not optional. Acute treatment effects happen during or immediately after therapy. Patients often suffer from mucositis, severe dysphagia, nausea, and vomiting. To survive this intense period, nutritional support is absolutely vital. Feeding tubes are frequently required to prevent severe malnutrition and dehydration. Then, we must manage the long-term effects. Up to half of all patients may develop hypothyroidism. Their thyroid simply stops working after radiation. This requires permanent, lifelong clinical monitoring. They may also suffer permanent loss of taste and decreased tongue mobility. Finally, specialized dental evaluations are required before treatment even starts. This mitigates the massive risk of dental decay caused by radiation to the salivary glands. Looking at this complete clinical architecture map, we can synthesize everything we've learned today. You can trace the entire pathway. Start with a single initial symptom, like hoarseness. From there, we identify the exact etiology, perhaps tobacco use. Next, we determine the precise TNM stage, let's say stage 2. Because it is laryngeal cancer and it is stage 2, this clinical framework leads us directly to our targeted modality. We choose organ preservation through radiation. Every symptom, every origin, and every stage has a precise path. This comprehensive framework shifts our care from being reactive to being highly customized and proactive.